Hi, I'm Jeff, the OT Dude, and this video will review hearing loss for the NBCOT exam. I also have a video, by the way, on vision loss as well, so be sure to check that out. The link will be in the description below. This video will be a little bit more extra and will cover the definitions, anatomy, pathophysiology, conditions, comorbidities, research, occupational impact, OT evaluation, screening, and interventions. It will be a little bit more didactic and comprehensive than my other NBCOT exam prep videos, but as many, including myself, did not really go deep into this topic in OT school, I decided to make a more deep dive educational review video. Even if you don't get tested on this topic necessarily, I think it'll be well worth your time to watch it in its entirety, as this will address the OT side of things that you will definitely benefit from in your OT practice, no matter like the setting you decide to practice in. So let's get functional. A little bit of advocacy first. I couldn't really find a position paper or much research from the AOTA or the American Journal of Occupational Therapy regarding hearing loss, but according to a statement by the World Federation for Occupational Therapists, individuals practicing in the profession are encouraged to have a broad education in the medical, social, behavioral, psychological, psychosocial, and occupational sciences. The WFOT has raised awareness about hearing loss through the World Health Organization, in fact. Some of these efforts are, but not limited to, the promotion of new assistive devices. And we should care because impaired hearing, although often considered as a comorbidity, can be a risk factor for falls, injuries, and cognitive decline, to name a few. Hearing loss can increase the risk for dementia and even depression. What's more, hearing loss can result in a loss of function and decreased quality of life, as well as decreased participation in occupations from ADLs to leisure activities. There's a psychosocial impact as well. Even though the NBCOT exam will be testing your knowledge as a generalist practitioner, there is an assumption from the WFOT that new grads will have the knowledge and skills to provide evidence-based practice to individuals in need, including for sensory rehabilitation, which is what hearing loss encompasses for OT practice. And I get it, your OT program may not have covered extensively or even at all hearing loss, as this is considered a special practice area, but you may be expected to know how to address sensory loss even from a generalist perspective in terms of hearing loss. And I definitely have encountered this in my practice in adults and geriatrics. As a practitioner, you can help meet the needs of those with hearing loss to lead more meaningful lives. While we often address sensory losses, such as low vision, many patients or clients may be hard of hearing or deaf and can benefit from our services as occupational therapists. With hearing loss, two common origins of it, so to say, are one, congenital or at a young age, and two, in older adults with hearing loss associated with older age. It, of course, can happen any time in between these common times. You're probably aware of the term deaf, too, as well. This is different from hard of hearing. Deaf describes people who usually have no useful residual hearing and who generally use sign language as their primary mode of communication. Congenitally deaf are for those who were born deaf. Adventitiously deaf are for those who were born with hearing but lost it later in life. Hard of hearing often is used to describe people who have some residual hearing. You should not refer to those who are hard of hearing as the hard of hearing, but instead as people who are hard of hearing. Hearing loss is defined as the partial or complete loss of the ability to hear. Hearing loss has three primary types: sensory neural, conductivity, and mixed. Sensory neural results from a problem with the inner ear or the auditory nerve. This is often a permanent deficit. Intervention for sensory neural hearing loss includes hearing amplification, like with hearing aids, cochlear implants, and rehabilitation. Conduction hearing loss results from a problem with the middle or the outer ear. Conductive hearing loss is often treatable. Mixed hearing loss, the last type, just as the name suggests, has a combination of sensory neural and conductive etiology. And one way that hearing loss is categorized is by measuring it in decibels, or dB. Slight hearing loss begins at around 15 decibels all the way up to profound hearing loss, which is greater than 90 decibels. Hearing loss, particularly in children, may affect speech, language, motor, and social development, and subsequently educational development. Children may learn signing, such as American Sign Language or ASL, but in older adults, they have not had hearing loss prior. So, in fact, many older adults with hearing loss probably do not identify with deaf culture. As a personal example, I have a good neighbor who is an older adult with pretty significant hearing loss. I find myself using extremely high volumes to communicate with her, and it sometimes seems even ineffective when we are talking outside, for example, where it's very noisy. My neighbor shared with me how frustrating it is to communicate with family members, to have phone conversations, to deal with like affairs over the phone, like paying bills and things, and not being able to hear the other party, and how it even wears on her psychologically even. She has limited her social interactions as well and has become more isolated, I have come to find. I then found myself thinking that I should brush up on my skills for hearing loss as an occupational therapist. So, what is the cause of hearing loss? Well, both genetics and environmental factors may cause hearing loss. Complications during pregnancy and childbirth may also cause hearing loss. You probably learned that the eighth cranial nerve, the vestibular cochlear nerve, is responsible for hearing. Some syndromes are due to genetic mutations and are associated with sensory neural hearing loss. Environmental causes include excessive noise, like exposure, infectious diseases, other types of exposures, and trauma. In older adults, the most common cause of hearing loss is damage to the cilia in the cochlea, such as prolonged exposure to loud sounds. And you would imagine this with, older age and how many sounds they have been exposed to over the many, many years. In older adults with noise-induced hearing loss, they often lose the ability to hear higher-pitched sounds. Presbycusis is the slow progressive loss of hearing that goes with aging. In fact, 1 in 3 people by age 65 has a hearing loss. Some may have tinnitus even, or like the ringing in their ears. How many of you been to a loud concert or a club or something and have your ears like ringing afterwards, right? Yeah, so lower volumes, avoidance, hearing protection are important for all ages of life, really, to prevent hearing loss, in my opinion. How about comorbidities associated or originating from hearing loss? These include motor impairments, cognitive impairments, learning difficulties, developmental delays, sensory integration impairments, communication disorders, ADHD, physical problems, and like my neighbor's psychosocial or emotional problems even. More specifically, one study found comorbidities in children with fine motor delay and gross motor delay, visual motor integration disorders, bilateral integration disorders, verbal apraxia, vestibular disorder. Another study of children with hearing loss found sensory motor problems at school. Sensory neural hearing loss in children was associated with more difficulty with the vestibular system compared to typically developing peers without any hearing loss. And studies even suggest there may even be delays in the development of gross motor skills. I sure did not know this when I was thinking of like hearing loss, how it can have so many comorbidities with other conditions. But it kind of makes sense as hearing is such an important sense during development and for interaction with our environment during our development, not only our language and communication, but how we interact, right, with others in the environment and also use our use of gross motor skills, defined motor skills, and much, much more. For people with hearing loss, the role of OT depends on factors such as their age, educational level, comorbidities, culture, finances, and their interests, barriers to occupations, and more. There is no like one size fits all approach or frame of reference and that OT can use. So they should be more holistic and family or client centered for the role of OT in the management in hearing loss. Hearing loss has a ripple effect, not only for the patient, but for those around them, including family, friends, in the larger community, as the comorbidities can vary from visual motor integration to sensory integration to behavioral and so on. A collaborative approach between healthcare professionals and the family would be most appropriate, I think, no matter what the age in terms of the client that you're working with. So let's review some of the team members associated with hearing loss that the OT may work with. These include otolaryngologists, or ENT doctors, audiologists, and hearing aid instrument specialists. Training goes from the most for the ENT to the least for the hearing aid specialist in terms of like schooling. Each team member plays an important role, as you can imagine, in the education, diagnosis, testing, treatment, training, calibration, and overall function of hearing loss and assistive devices. You can pause the video now if you are interested in more of the specifics of what each professional does. So the most common answer that many may propose is, why not use hearing aids? Of course, hearing aids can be helpful for some, but not everyone. They may amplify unwanted frequencies, such as the lawnmower outside or the refrigerator in the break room, and it can make it hard to attend to sounds, such as conversations. I remember in one example during my fieldwork, one of the occupational therapists actually wore hearing aids and they were hard of hearing. And there was like a refrigerator like no more than 5-10 feet away. And whenever I noticed that we sat next to it, this occupational therapist often had trouble hearing and had to have us like repeat ourselves quite often, probably due to the unwanted noise and the distracting noises that were competing with our voices in the environment that were also amplified in the hearing aid. So that's just one example of how it didn't work that well in that situation. Hearing aids may also be uncomfortable to wear, especially for a long time. You probably worn like headphones for a long time, right? Now think about it wearing it all day. Not to mention, historically, hearing aids are very expensive and financially unfeasible for many. Also, losing them can be very stressful. Medicare and most insurances do not cover hearing aids. Then there's the cost of exams and hearing aid replacements, which should actually even happen every like 5 years due to, for example, changes in one's hearing. Functionally, hearing aids also pose barriers due to needing batteries, having a very small size, making them difficult to don and doff for fine motor skills, to clean, and if you should forget them to take them off in the shower, they could get damaged. For children in school, or even adults really, it can make them stand out from peers or others socially. So you potentially have a device that, has device abandonment, or people are even hesitant to try it altogether, even if they may benefit from it. Or if they want to use them, the battery may be dead or they may be misplaced. That's not to say hearing aids aren't appropriate at all, and they have their place, but it's not a one-size-fits-all approach or answer. Well, what about cochlear implants? They may be a feasible option, actually, for some. Cochlear implants are electronic devices that are surgically implanted and work by directly stimulating functioning auditory nerve fibers in the inner ear. Cochlear implants convert sound waves to electrical impulses and transmit them to the inner ear. So as occupational therapists, we should be holistic and creative even. We have a role to play beyond hearing aids and implants and assistive devices from the general sense. And we should explore alternative ways to help those with hearing loss maintain their function and to address their needs. Starting with evaluation, do you know how to assess for hearing loss? Sure, a chart review would be a good start, and sometimes charts may indicate HOH or hard of hearing, but you can also ask the patient or the client themselves in the evaluation even. Sometimes you may notice that during your conversations with them that they may not hear you, like your questions during your screen for other things such as range of motions, MMT, and other sensory testing like your directions or your questions. You can observe them how they function when interacting with activities that involve sound like live conversations, phone calls, watching TV, and like what the volume is at if it's like really, really loud. And how about this? Can you think of a way to screen for someone who is hard of hearing? I make it a habit to screen for hard of hearing loss using a simple test called the whisper test. The OT stands at arm's length behind the patient and tests one ear at a time by having the patient cover one ear, and the OT whispers a series of random numbers and letters like A7Q, but I whispered, of course, and A7Q, and has the patient repeat it back to you. And another is the finger rub test, where you rub your fingers together about 6 inches away from the ear and ask if they can hear it. In terms of a formal screen, there is the hearing handicap inventory for the elderly that asks questions and interprets the results in categories that's kind of nice, as no handicap to all the way severe handicap. It also has high test retest reliability, so that's good. Oftentimes, I encounter patients who either have no hearing aids, left them at home, the batteries are dead, or the device is not calibrated, or it's not good for the patient like anymore, such as being really, really old. Kind of like how your glasses are too old for your prescription. So on my acute rehab unit, we have a simple voice amplification device, which is basically like a microphone attached that's part of a box with like batteries that's attached to headphones that you can plug in and plug out that can help the patient hear better. It doesn't really work 100%, but at least it prevents the staff from yelling every time on a unit that promotes, like rehabilitation and healing. Other communication methods in collaboration with, say, speech-language pathology may be helpful, such as written whiteboards or even like pre-made communication cards that you can point to that are like more universal, like they have like drawings that people can understand no matter the language even. Some of the OT interventions that I will go over come from a really well-researched and insightful OT doctorate thesis by Kristen Chang. She categorized interventions for hearing loss in older adults into 3 categories: assistive technology, acoustic environmental modifications, and 3 compensatory strategies. You're probably familiar with a lot of hearing assistive technologies already, which basically substitute audio with other senses, such as your visual or tactile stimuli. Closed captioning, CC, for TV, even for smartphones these days, are becoming more widely available and already come built in, for example. Some phones can provide active noise cancellation to reduce the background noise and use like even flashing lights for incoming calls. There are captioned telephones, and of course, video calling as an option such as FaceTime, which enables things like lip reading and sign language. Sound settings for devices can be adjusted, such as by increasing their treble, as in bass and treble, to bring out the human voice frequencies better, as older adults often have hearing loss in the higher frequencies first. A place to look is in the settings on electronics or in the accessibility section in the settings on computer devices. And it may be tempting to adjust these settings for your patients, but we should I'll empower people, right, with hearing loss by having them do it themselves, such as like walking them through it and having them do it. Many hard of hearing applications can be downloaded to help make lives easier, as well as I'm sure they're being added every day to the app stores. For example, the latest update for my Android phone allows my live phone calls to be captioned simultaneously, like live on the screen. So that's really, really cool. Transcripts are sometimes available, such as for podcasts. Even YouTube has added this feature recently for videos, like video transcripts, in addition to their existing automatically generated closed captioning. I talked about hearing aids earlier, and the OT practice framework even has language for the role for the OT in hearing aids under personal care device management as a health management occupation. This includes hearing aid donning and doffing, cleaning, maintenance, and is definitely well within the realm of the OT's scope of practice. So you should be familiar, I think, with how to help someone don and doff both pairs of hearing aids properly. You should be familiar with how to change out the battery, clean it properly, reminding or where to store it safely in a safe place so that you don't lose it, and so on. And providing as few cues as possible unless to intervene for like safety, such as like it getting wet in the shower or something. And going back to assistive technology, many newer hearing aids sync with phones, such as via Bluetooth, and have apps associated with the model. People with hearing loss should not be afraid to experiment with different settings and modes for their hearing aids with these apps, because they can really just revert back to their default settings, and there's just no like really messing things up if they don't like how it sounds afterwards. Every situation is different and everybody's different, and one setting may work better in one environment even or circumstance than another for the same person. So experiment. They can change things, even like the sound and the EQ or equalizer, and have saved presets to quickly switch between them with like a press of a button on the hearing aid without even using the app. So pretty cool. And as they are connected via Bluetooth, these connected hearing aids can even take phone calls. And there are two types of hearing aids even. One where each left and right side amplify individually sounds. And another one for one-sided hearing loss, for example, is called crossover hearing aid, where one side passes the sound to the other ear. Also, there's another category of assistive technology called alerting devices for hearing loss that use other non-auditory means for notifications of, say, when the tea kettle is done. There are fire alarms, baby monitors, kitchen timers, doorbells, and alarm clocks that use these kind of features. Did you know that there are even certified hearing dogs? A hearing dog has completed training to alert the owner to certain sounds in different environments. Okay, so category 2 in terms of OT intervention. What about the acoustic environment? Imagine being in a busy city street or trying to talk on the phone compared to talking on the phone in a quiet room like in the library. Even for someone with normal hearing, they could have a difficult time, let alone someone who is hard of hearing, right? So you can do two things. Speak up and amplify what the person wants to hear, and or you can reduce the background noise. Have you ever noticed how when you drive on the freeway in your car and you listen to like music, or you have your headphones on in an airplane, that you have to turn the volume way up when the environment is louder? It's the same concept. The environment can also be modified then, basically reducing the sounds to improve hearing, such as treating the rooms to reduce echoes, like in movie theaters or in recording studios, kind of like how I have behind me sound treatment. But it can be done even with everyday objects in people's homes. In an unfurnished room or in a hallway, if you were to like clap really loud, you would hear a lot of echoes and reverberations, and it sounds really bad. Do the same in a room that is more treated, such as like a living room that has like furniture, rugs, bookshelves, things that can absorb the sound. It's much easier to hear things like conversations because they don't reverberate. And like when you watch movies really loud, it just sounds much better. This is an area that OTs can help by providing modifications to the environment. But it's a balance really that requires you to exercise your critical thinking, because you may not want to add things like throw rugs, even though they're better for sound in terms of like treatment, but they can also pose a fall risk, right? So even though it may be better for the acoustic environment, you have to kind of balance it with safety. And this is a whole thing itself, but this provides a good introduction to treating the environment, such as someone's home. And sometimes, you can't do that, such as when someone's in public who has hearing loss. But choosing the environments that you go to can help, such as a library or a museum you can imagine is much quieter than a coffee shop or a busy restaurant. So maybe sometimes you have choices, such as like grocery store you visit. Maybe one is quieter. And if you're curious, or you can even teach this to your clients, that they can download an application such as one that measures the decibels in the environment to get an idea of how loud an environment is, to give them more insight into their situation so that they can avoid it, for example, based on this kind of real world scientific data. So what can people who are hard of hearing do when they can't change or modify the environment? I kind of went into that already, right? So avoidance, but also choosing maybe the different times that you go to is another option. But it's not really just even limited to the environment. There's also social factors. So the last approach for OT intervention with hearing loss are compensatory techniques. Starting with communication, you can practice and teach your patient strategies such as maintaining eye contact, facing the individual so that they can read your lips, having good lighting, using more facial expressions to show your emotions, and not have like a flat affect, and not having distracting things in your mouth, such as chewing gum while you're talking to them. And unfortunately, with like the pandemic, we may not have a choice with like face masks and our sounds are more muffled. So we might have to get a little bit more creative when it comes to communicating with those who are hard of hearing, right? Like I've seen those masks that are kind of transparent. You can see people's lips and do more lip reading. Pretty cool. And where one who has hearing loss positions themselves relative to other people or other sounds that they want to hear makes a huge difference, right? I have a family member who is deaf in one ear and not the other. They have like normal hearing in the other. So it makes sense to kind of sit and talk in their good ear side. My family member tells me that in like college lecture halls, they like to sit against the wall with the wall next to their deaf ear and their good ear facing the rest of the room. This not only prevented people from speaking on their bad side because, well, there's a wall there, but it allowed them to hear everything on their good ear. So with hearing loss, it's not always necessarily equal in both ears. Some people may have better hearing in one or the other, or they may be deaf in one and not the other. Even find this out in your hearing screening tests or evaluation with your patients. The way we speak also makes a difference. The rate and amount of pauses and use of tones and sounds we emphasize can make a difference too. If you're soft-spoken and it's not like just about speaking up either. If someone does not hear us, we should try to repeat the meaning or what we're trying to say in a different way. And so we can use different sounds or other phrases, other sentences that the person may pick up better on. It's not always about just raising our voice and volume either. And to give you an idea of what like OTs can do in terms of occupations, more specifically, for example, with like IADLs, when driving, people who are hard of hearing can turn down the radio or turn it off even. They can go at less busy times for shopping, like grocery shopping, and use self-checkout because there's a screen there instead of having to talk to a clerk. So it's kind of like changing one's habits, roles, routines, that kind of thing in the OTPF that can help people promote occupations to overcome their barriers to hearing loss. They can use text-based methods, right, for booking appointments, such as online instead of talking to somebody over the phone. Like one of the guest speakers who were legally blind and did like an in-service at my workplace said, we definitely live in a great time to have sensory loss, such as hearing loss, as technologies basically, such as smartphones and apps and assistive technologies combined with compensatory techniques and environmental modifications can do a whole lot more for our function. Last, I will talk a little bit about deaf culture. People who are culturally deaf use an uppercase D in the spelling of the word deaf, D-E-A-F. People who are audiologically deaf use a lowercase d and may use their residual hearing with assistive devices, for example. Deaf should be used as a descriptor, just like hard of hearing, such as people who are deaf and avoiding the phrase the deaf. And you may be wondering, what else can you do to be more knowledgeable and be able to help those with hearing loss as an occupational therapist in your future practice? Well, when I was doing my level 2 fieldwork at my hospital, my clinical instructor recommended that I learn some American Sign Language, or ASL. Now I really see why she recommended that. That could be something you pick up even as you practice as an OT, even if it's signing simple phrases. You can even start like right now learning on YouTube and for free. So I hope this helps. If you found this video helpful, give it a thumbs up and share with your study group. I'm Jeff, the OT Dude. Thanks for watching and good luck studying.